Most people who are diagnosed with Sjögren syndrome hear a version of the same explanation. It's genetic. It's autoimmune. Your body is attacking the glands that produce moisture. That's why your eyes are dry. That's why your mouth is dry. And the treatment? Artificial tears. Maybe a saliva substitute. Possibly some medication to manage symptoms. And for a lot of people, that explanation feels incomplete. Not wrong, but incomplete. Because the dryness, as uncomfortable as it is really just the most visible symptom of something much more complex happening beneath the surface. So what if we looked a little deeper? Not at a single cause, because honestly, science hasn't identified one, but at the web of contributing factors that may help explain why this condition develops, why it flares, and why treating only the symptoms often leaves people feeling like something is still being missed. That's what this video is about. We're not going to make dramatic claims. We're not going to tell you doctors are hiding something. We're going to walk through what the research actually shows, clearly, carefully, so you can have more informed conversations with your healthcare team. Let's get into it. If you've been diagnosed with Sjögren's, or you suspect you might have it, chances are you've been told something along these lines. You have an autoimmune condition. Your immune system is mistakenly attacking your moisture-producing glands, particularly the ones that make tears and saliva. Certain genes make you more susceptible. There's no cure, but we can manage your symptoms. And that explanation is accurate. It's backed by decades of research. But here's where a lot of patients start to feel a disconnect. The treatment plan often focuses almost entirely on replacing the moisture your body isn't making enough of. Artificial tears for the eyes, saliva substitutes, or prescription medications like pilocarpine for the mouth may be lubricants for other forms of dryness. And those treatments help, genuinely. They reduce discomfort, they protect your eyes and teeth from damage, they improve quality of life. But they don't address the underlying immune activity that's causing the dryness in the first place. Think of it this way. If your basement is flooding because a pipe burst, putting down towels helps manage the water on the floor. That matters, but it doesn't fix the pipe. For many Sjögren's patients, the dryness is the water on the floor. The immune system dysfunction and whatever's driving it is the pipe. And this is where the standard narrative starts to feel thin. Because when someone asks, "But why is my immune system doing this?" the answer is often, "We don't fully know. It's probably genetic." Which brings us to the genetics question. Because yes, genetics are part of the picture, but they are not the whole picture, not even close. Research has identified several genes that increase susceptibility to Sjögren's, particularly genes in the HLA system, which is part of how your immune system identifies threats. Variants like HLA-DQB1 and HLA-DQA1 appear more frequently in people with Sjögren's. But here's the thing. Having those gene variants doesn't mean you'll develop the condition. Plenty of people carry those variants and never develop Sjögren's, and some people who develop Sjögren's don't carry the expected genetic markers at all. Genetics loads the gun, but something else pulls the trigger. And that something else is what doesn't get enough attention. Before we talk about contributing factors, let's make sure we understand what Sjögren's actually is, because it's often undersold as just a dryness condition. It's much more than that. In 2025, the medical community officially changed the name from Sjögren's syndrome to Sjögren's disease. That wasn't just wordplay. It was a deliberate recognition that this is a serious, systemic autoimmune condition that can affect the entire body. So here's what's happening at the most basic level. Your immune system, which is designed to identify and attack foreign invaders like bacteria and viruses, begins targeting your own tissue instead. Specifically, it sends immune cells to infiltrate the glands that produce moisture, the tear glands, the salivary glands, sometimes glands in other parts of the body. These immune cells, primarily certain types of T cells and B cells, set up camp in those glands and create chronic inflammation. Over time, that inflammation damages the glandular tissue. The glands produce less moisture, and you experience dryness. But here's what a lot of people don't realize. Sjögren's doesn't stop at the glands. Up to half of people with Sjögren's develop what are called extraglandular manifestations. That means the immune dysfunction can affect other parts of the body, the joints, the lungs, the kidneys, the skin, the nervous system. Many patients experience crushing fatigue, joint pain, brain fog, difficulty concentrating, memory problems, numbness or tingling in their hands and feet, a persistent dry cough that won't go away, skin rashes. A 2025 survey of more than 6,000 Sjögren's patients found that the symptom with the greatest impact on quality of life wasn't actually dryness. It was fatigue, followed by joint pain, then brain fog. Dry eyes came in fourth. So when we talk about Sjögren's, we're not talking about a minor inconvenience. We're talking about a condition that fundamentally changes how people experience their daily lives. And here's one more thing that's important to understand. The B cells, those immune cells that are causing so much trouble, they produce autoantibodies, proteins that target your own body. In Sjögren's, the most well-known ones are called anti-SSA, also known as anti-RO, and anti-SSB, also known as anti-LA. These autoantibodies are used for diagnosis, but they also tell us something important about the nature of this disease. This isn't just inflammation happening in one spot. This is a systemic immune response. It's happening throughout the body, and it's self-sustaining, meaning once it starts, it tends to keep going. That's why the question of what starts this process, what shifts the immune system from normal function into autoimmune attack, is so important, and why the answer, it's just genetics, has never fully satisfied researchers or patients. Now let's get into the part of this conversation that doesn't happen enough. What we're about to discuss are contributing factors, not confirmed causes. That distinction matters. Science has not identified a single definitive cause of Sjögren's disease. What researchers have identified is a collection of factors that appear to interact with one another in complex ways, and that may influence whether someone develops this condition, how it progresses, and what triggers flare-ups. Think of it less like a light switch, one thing that turns the disease on, and more like a web. Multiple threads woven together, creating conditions in which the immune system goes off course. Let's walk through them. At the core of Sjögren's is a breakdown in immune regulation. In a healthy immune system, there are checks and balances. Certain cells promote inflammation, that's necessary when you're fighting an infection. Other cells dial that inflammation back down once the threat is gone. Regulatory T cells, for example, act like brakes on the immune response. In Sjögren's, that balance is disrupted. The inflammatory side becomes overactive, and the regulatory side can't keep up. B cells, which normally produce antibodies to fight infections, become hyperactive. They start producing autoantibodies that target the body's own tissues. They also produce excessive amounts of a molecule called BAFF, B-cell activating factor, which keeps them alive longer than they should be and promotes even more B-cell activity. It becomes a self-reinforcing cycle. Meanwhile, certain types of dendritic cells, particularly plasmacytoid dendritic cells, begin producing high levels of type 1 interferon, a signaling molecule that ramps up immune activity even further. And a protein called LAMP3 becomes overexpressed in the epithelial cells of the salivary glands, driven by those elevated interferon levels. This promotes damage to the gland tissue and triggers additional innate immune responses. What makes this particularly challenging is that once this cycle is established, it appears to become self-sustaining. The immune system essentially gets stuck in attack mode, and the inflammation it creates causes tissue damage, which exposes more cellular material to the immune system, which creates more inflammation. This is why researchers have been so focused on developing targeted therapies, medications that intervene at specific points in this immune cascade, rather than just managing the downstream symptoms. And this is also why it's important to understand. Something has to initiate this cycle. Genetics create susceptibility, but the cycle itself appears to need a trigger. Of all the potential triggers that have been studied, viral infections have received the most attention, and the evidence, while not definitive, is compelling enough that this remains one of the active areas of Sjögren's research. The virus that has been most consistently linked to Sjögren's is the Epstein-Barr virus, or EBV. This is the virus that causes mononucleosis, mono. Most people are exposed to EBV at some point in their lives. In fact, the vast majority of adults carry the virus in a dormant state. But in people with Sjögren's, researchers have found unusually high rates of EBV reactivation, meaning the virus becomes active again. They've found elevated levels of EBV DNA specifically in the salivary glands, and they've found that the immune system in Sjögren's patients appears to struggle to keep EBV under control in those glands. The proposed mechanism involves something called molecular mimicry. The idea is that certain viral proteins may structurally resemble the body's own proteins closely enough that the immune system, in attacking the virus, accidentally begins attacking the body's own tissue as well. Once that confusion is established, the autoimmune process may continue even after the viral infection is resolved. Other viruses that have been studied in connection with Sjögren's include hepatitis C, human T-cell lymphotropic virus type 1, cytomegalovirus, and more recently, SARS-CoV-2, the virus that causes COVID-19. Some preliminary research has identified Sjögren's-like symptoms developing after COVID infection, though this area is still very early. Now, and this is important, none of these viruses have been confirmed as a direct cause of Sjögren's. The relationship is complex. Many people are exposed to these viruses and never develop any autoimmune condition. And some Sjögren's patients don't show evidence of any of these specific viral triggers. What the research suggests is that in someone who is already genetically susceptible, a viral infection, particularly one that affects the glands, may act as the event that initiates or accelerates the autoimmune process. And interestingly, antiviral medications have not been shown to help treat established Sjögren's. This supports the idea that the virus may act as a trigger, but once the autoimmune process is set in motion, it becomes independent of the original infection. The fire keeps burning even after the match has gone out. Here's a statistic that immediately tells you hormones are part of this story. 9 out of 10 people diagnosed with Sjögren's disease are women. That's a dramatic skew, one of the most extreme sex differences in any autoimmune condition, and it strongly suggests that sex hormones play a role. The hormone that has received the most research attention is estrogen. There's an interesting pattern. The risk of developing Sjögren's appears to increase after menopause when estrogen levels decrease significantly. Some researchers have proposed that estrogen may have a protective effect on the exocrine glands, and that losing that protection may create vulnerability. Animal research has provided some support for this. Studies have shown that estrogen deficiency can lead to increased expression of a protein called RBA-P48 in salivary gland cells, which promotes a form of cell death that may contribute to glandular dysfunction. Mice models with overexpressed RBA-P48 developed autoimmune gland disease that resembled Sjögren's. Researchers are also exploring the role of the X chromosome itself. Since women carry 2 X chromosomes and men carry 1, there may be genes on the X chromosome that influence immune regulation in ways that increase autoimmune risk. None of this means that hormonal changes cause Sjögren's, but hormonal shifts, particularly the decrease in estrogen around menopause, may be one of the factors that contributes to the conditions under which the disease can develop or become more active. Beyond infections and hormones, researchers have also examined broader environmental factors. Exposure to certain chemicals, particularly solvents and some inorganic compounds, has been associated with increased risk of Sjögren's in some studies. The exact mechanisms are not well understood, but the theory is that chemical exposures may trigger immune dysfunction in susceptible individuals, potentially through oxidative stress or direct glandular damage. Dietary factors have also drawn attention. Research has found that some Sjögren's patients show high sensitivity to gluten, and that gluten exposure may be directly related to inflammation in those individuals. While this doesn't apply to every patient, it suggests that for some people, dietary factors may influence the severity of their symptoms. More broadly, the inflammatory potential of a person's overall diet, sometimes called the inflammatory load, has been linked to autoimmune disease activity in general. Diets high in processed foods, refined sugars, and certain types of fats have been associated with higher levels of systemic inflammation, while diets rich in whole foods, omega-3 fatty acids, and plant-based nutrients have been associated with lower levels. Again, no one is claiming diet causes Sjögren's, but the nutritional environment of your body may be one of several factors that influences how active the disease is. Chronic, low-grade inflammation, the kind that doesn't produce obvious symptoms but simmers beneath the surface, has been increasingly recognized as a contributor to many autoimmune conditions. In Sjögren's, researchers have found elevated levels of inflammatory markers like interleukin-6 and TNF-alpha in the tears and tissues of patients. These aren't just bystanders, they actively correlate with disease severity. There's also growing interest in the connection between gut health and immune regulation, sometimes discussed as the gut-immune axis. While this research is still in relatively early stages for Sjögren specifically, the broader understanding in immunology is that the gut plays a significant role in how the immune system is trained and regulated. Disruptions in gut health, sometimes called dysbiosis, have been associated with various autoimmune conditions. This is an area where the science is evolving rapidly, and it's too early to make specific claims for Sjögren's, but it's worth being aware of as a factor that researchers are actively exploring. If you've ever noticed that your symptoms get worse during stressful periods, you're not imagining it. The relationship between psychological stress and immune function is well established in the broader medical literature. Chronic stress activates the hypothalamic pituitary adrenal axis, the body's stress response system, and produces sustained levels of cortisol and other stress hormones. Over time, this can dysregulate immune function in ways that may promote autoimmune activity. Some research has specifically examined the HPA axis in Sjögren's patients and found evidence of hypofunction, meaning the stress response system itself may not be operating normally. There's also the relationship between Sjögren's and mental health. Depression and sleep disturbances are common among patients, and these conditions can further influence immune regulation, creating additional feedback loops. This doesn't mean stress causes Sjögren's, but chronic stress, particularly when sustained over long periods, may be one of the environmental factors that contributes to immune dysregulation or triggers disease flares in someone who is already susceptible. Many patients report that learning to manage stress more effectively, with whatever methods work for them, helps reduce the frequency or severity of their flare-ups. And research supports that general principle, even if the specific mechanisms in Sjögren's are still being mapped out. Let's come back to where we started. Artificial tears, saliva substitutes, symptom management. These treatments are valuable. I want to be really clear about that. If you have Sjögren's, managing your dryness is not optional. Chronic dry eyes can lead to corneal damage and vision problems. Chronic dry mouth dramatically increases your risk of dental cavities, gum disease, and oral infections. These are real consequences that need active management. But here's the gap. For decades, symptom management was essentially all that was available. There were no approved medications that targeted the underlying immune process driving the disease. Doctors could manage what Sjögren's was doing to you, but they couldn't address why it was happening. That's why many patients have felt frustrated. You can use artificial tears every hour and still feel like the disease is progressing because the immune attack on your glands hasn't stopped. You're just replacing some of what it's destroying. The good news, and this is significant, is that this is changing. For the first time, there are targeted therapies in advanced clinical trials and some approaching regulatory approval that directly address the immune mechanisms driving Sjögren's. Medications that target B-cell activity, medications that block the signaling molecules that keep the autoimmune cycle going, medications that reduce circulating autoantibodies. The results from recent clinical trials have been described as historic for the Sjögren's community, the first time that Phase 3 trials have shown statistically significant reductions in disease activity. This is an area worth following closely. The treatment landscape may look very different in the coming years. If you're a Sjögren's patient, talk with your rheumatologist about whether any of these newer approaches might be relevant to your care. But even as these new treatments emerge, understanding the contributing factors we've discussed remains important, because immune-targeted medications address the downstream immune dysfunction, but the upstream factors that initiated that dysfunction and that may continue to fuel it are things you and your healthcare team can also consider. It's not one approach or the other, it's both. If you have Sjögren's, or suspect you might, here are some things worth paying attention to and discussing with your healthcare provider. First, symptom patterns. Many patients notice that their symptoms aren't constant, they fluctuate. There are better periods and worse periods. Paying attention to what corresponds with those fluctuations can be extremely valuable. Some people find that stress, poor sleep, dietary changes, hormonal cycles, or illness correspond with symptom flares. Keeping a simple journal, even just noting how you feel each day and what's happening in your life, can help reveal patterns that aren't obvious otherwise. Second, the full range of your symptoms. Sjögren's is often diagnosed based on dryness, but if you're also experiencing fatigue, joint pain, brain fog, numbness, rashes, or other symptoms, make sure your healthcare provider knows about all of them. These extraglandular symptoms can influence treatment decisions and may help your doctor assess disease activity more completely. Third, don't wait too long for a diagnosis. Sjögren's is notoriously underdiagnosed. It's estimated that roughly half of people who have it haven't been diagnosed yet. The average delay from symptom onset to diagnosis has historically been several years. Part of the reason is that early symptoms, dry eyes, dry mouth, fatigue, are common and can easily be attributed to other causes. If you have persistent, unexplained dryness, especially combined with fatigue or joint pain, bring it up with your doctor. Ask about testing for Sjögren's-related antibodies. Consider seeing a rheumatologist. Fourth, dental care matters more than you think. This is one of the most practical things you can do. Chronic dry mouth dramatically increases your risk of cavities and gum disease. See your dentist regularly, more frequently than usual if possible. Use fluoride treatments. Avoid sugar. Brush and floss carefully. This sounds simple, but protecting your teeth is one of the most impactful things you can do for your long-term quality of life with Sjögren's. Fifth, stay informed about emerging treatments. The treatment landscape is evolving faster now than at any point in the history of this disease. Organizations like the Sjögren's Foundation provide reliable, up-to-date information about clinical trials and new research. Being informed allows you to have more productive conversations with your healthcare team about your options. Let's bring this full circle. Sjögren's disease is complex. It's not caused by one thing. It's not explained by genetics alone, and it's not adequately treated by addressing symptoms alone. What the research shows us is a picture of multiple contributing factors: genetic susceptibility, immune system dysregulation, possible viral triggers, hormonal influences, environmental exposures, chronic inflammation, and stress interacting in ways that are still being fully mapped out. No single factor tells the whole story, but taken together, they begin to explain why this condition develops, why it affects people differently, and why it can be so difficult to manage. And understanding that complexity isn't discouraging, it's actually empowering, because it means there isn't just one lever to pull, there are many. And while we can't control our genetics and we can't undo a past viral infection, there are factors within this web that we may be able to influence, whether through working with our healthcare team on immune-targeted treatments, managing stress, paying attention to dietary and environmental factors, or simply being more aware of what our bodies are telling us. The goal is not to find a single hidden cause. The goal is to build a more complete picture, so that treatment can be more than surface level, and so that conversations between patients and doctors can go deeper. If you're living with Sjögren's, you deserve more than just being told to use artificial tears and manage. You deserve to understand what's happening in your body, and you deserve a healthcare team that's willing to look at the full picture with you. Understanding what may be contributing is often the first step towards managing what you're experiencing. If this video helped you see Sjögren's more clearly, share it with someone who might benefit. And if you have questions or topics you'd like explored in future videos, leave them in the comments. Take care of yourselves.